And welcome to our February Lunch and Learn, where we are going to talk about the IDD pilot program that is going on, and Florida Community Care is going to take the lead. I see that Callie is on, and I believe Carol is on.
Yep, it looks like it.
I'm looking for, there she is. There she is. So I know that for those of you that participated in one of our advocacy meetings last fall, we had Florida Community Care talk about the launch of the pilot, but there's been some updates and new things, and so we thought that we would just have them come back again and do an informal presentation and answer any questions and concerns that anyone has. So I'm going to let Carol take the lead when you're ready.
Here and let Callie introduce herself because she's also part of our team.
Yep. Hi, my name's Callie Wilson. I am the IDD program director here at Florida Community Care. Both my personal and professional history is both with this population. I have 3 children. 2 of them have intellectual and developmental disabilities. One is actually currently being served under the iBudget Med waiver and actually resides at the ARC Tampa Bay. So very happy with the services she's getting. She actually moved into her group home 1 year ago today. Crazy to think. But she's doing very well, and we're very happy with the services she's receiving. I actually worked at the ARC Tampa Bay for about 8 years. I started as the behavior intensive nurse and then became the medical director and then subsequently the associate executive director over medical and behavior. Over medical and residential programming. I also am on the Florida Developmental Disabilities Council. I've been a board member on that in that platform since 2018. So, and now I'm here at Florida Community Care, assisting in the Medicaid pilot program. So excited to be here. Carol, are you back on mute?
I'm on mute.
No, you're good. Okay.
Okay, sorry.
No, you're good. Can you,
Okay.
Carol, since you understand the Medicaid language much better than I do, can you explain what a provider, we're provider owned. So can you explain what that means?
Sure.
Okay.
So the state of Florida, since legislation was passed in 2011 and since the Agency for Healthcare Administration implemented that legislation in 2014, Florida has had a managed care system for providing coverage and services to the Medicaid population. And that means that almost 90% of the people who depend on Medicaid for medical benefits receive those benefits through managed care organizations. And the Florida law defines 2 types of organizations that can qualify as managed care organizations. One is your basic insurance company that is a licensed HMO. And, tend to be those large companies that you've heard of before: United, Humana, Centene, Aetna, so forth. And, but Florida also did a unique thing, and it particularly was trying to encourage providers to organize themselves as networks of care that would be capable of managing enrollees' need for health services for all different types. And independent living systems, which has been a corporation in the state of Florida for more than 20 years and doing things like providing care coordination, home delivered meals, durable medical equipment, things like that. And also serves as the lead agency in Miami-Dade, one of the 2 lead agencies in Miami-Dade for the community care for the elderly program. So we were definitely in the business of providing services and in a position that we could organize along with some other providers as this unique category that Callie mentioned. It's called a provider service network. And I really think that gives us a slightly different identity in the world. We see our mission in the world not so much in terms of processing claims and managing paperwork, although we have that skill set as well. But we were created to provide services to individuals and patients and clients, and that's our main mission in the world. So that's the background. We can entertain any questions that you may have about that. But I would like to go now to the background on the pilot program. And I know some of you may have been in ARC Florida's previous advocacy discussion about this issue, so you may be familiar with it, and I apologize for repeating some of the same information, but others may be new to it and just have heard bits and pieces around. So if you'll bear with me, I'm going to go through a little bit of the history of the program and explain what it is. And then hopefully we'll get to the fun part, which will be the dialogue, the back and forth between us, the questions that you may have, or the discussion that we might want to have about ways to meet the needs of persons with intellectual disabilities. The background for this pilot is that it was created by an act of the legislature in 2023. It was, in fact, the brainchild of the now speaker, Danny Perez. He is an individual who has a family member with a developmental disabilities, and so he had been paying attention to the way in which the state offers services to this population, and he saw some problems with that. And I will tell you that the problems he particularly drew attention to were the fact that Florida seemed unable to really make a significant dent in the number of people who are on the wait list for services. And in spite of the fact that the legislature made very significant investments to try to accomplish exactly that. Secondly, he had seen in the last few years that the agency for persons with disabilities was not spending all of their appropriated funds and was in fact returning money to the state treasury. And he was very sensitive to the fact that there are needs out there that were not being met, and was frustrated by the fact that the money was available but not being spent effectively. So he wanted to try a different way to deliver services, to organize those services, to fund those services, and what he turned to was a managed care model. And part of the reason for that, I know there's still strong feelings about managed care, particularly with all of the policy changes that have been recently instituted. But part of the reason to have some degree of confidence that a managed care model might work for a population that has both medical and social needs is because Florida has had a lot of success in the long-term care world. And that, in fact, is where Florida Community Care has mostly done its work since 2018. We've been a statewide long-term care plan. In the new contract that started February 1, we are expanding to other Medicaid populations. But in any case, our history is on serving people with complex and medical problems or challenges who need both supports in the home as well as medical care coverage. And Florida's success in the long-term care space enabled it in that period of time from 2014 when it was first implemented to today. They've tripled the number of people that are enrolled in that program and receiving services through that program. They went from right around 38,000, 42,000, something in that neighborhood. I didn't pull those numbers up, but it was in that neighborhood. We're now at almost 150,000. So, and the reason for that is because a managed care model gives you the opportunity to achieve some efficiencies and deliver services where you emphasize home care and community-based care. And we've rebalanced the location of services and saved money that otherwise would have been spent in nursing facilities for institutional care. So that was the background to the model. And then in 2023, the legislature created a pilot. The document that Dina has shared her screen shows the areas that it served. Specifically, the people that are eligible to participate in this pilot program are individuals who are eligible for Medicaid. They're adults age 18 and over, and they reside in these two specific geographic areas that are shown with the orange coloring on the map of Florida. There's about 7 counties that are included in the pilot area. And then in addition to that, an individual to be eligible needed to be in a on the wait list in a pre-enrollment, any pre-enrollment category, but on the wait list, and then voluntarily choose to participate in the pilot. So there was absolutely no mandatory assignment in this pilot. It is totally up to the individual and their families to decide they want to participate. The goal of the program is basically to create a model of delivering services that has greater flexibility, that might in fact be capable of increasing the number of providers who are participating and available to serve that population, and to provide very high quality care coordination and person-centered care. So we, to give you a few statistics, we went live in October 1. I guess I should go back one other step and say that that Florida Community Care was selected through a competitive procurement that was run by the Agency for Healthcare Administration. There were 2 plans that bid on that procurement, and Florida Community Care won that bid as the sole plan in the pilot program. The program went live October 1, and since October 1, there have been 319 individuals enrolled. That 319, that number, the enrollment number, you know, of course, changes day by day by day. That is the most recent number for last week, I believe. So, it's also important to mention the process by which a person who is eligible to participate in the pilot can actually get enrolled. So APD is managing the front end of the enrollment process. They, of course, maintain the wait list. So they use that wait list to identify potentially eligible individuals who live in that appropriate geographic areas. In late August, they sent out letters to about 2,700 people that they had determined might be eligible to participate. They explained briefly what the pilot was, and they asked anyone who was interested to return a form to APD that indicated that interest. And then from that point forward, APD also was trying to accomplish 3 primary tasks that they felt were essential to be complete before an individual's name was turned over to ACA for enrollment in our plan. Those three things were they wanted to make sure that the individual was actively enrolled in Medicaid. Secondly, they wanted a current QSI done, and that is what level of support and services they need. And thirdly, they wanted a completed HCBS form, home and community-based service form, or level of care form. It's sometimes referred to, it's a one-page document. Again, the individual or their caregiver, their family member is checking the box to indicate what their type of disability is, what their level of care need is, and they're signing the bottom of it to indicate their interest in receiving home and community-based services. So those three tasks have actually been the reason why many of the people who submitted interest forms did not immediately get enrolled. We've seen a very modest growth in the number of enrollees. We're now, I mentioned to you, at about 319. And there's still, the APD received over 600 interest forms. So that suggests a gap of about 300 persons who haven't yet made it all the way through the pipeline and onto our enrollment list. So that's been a little bit concerning that takes so long for that to happen. But once somebody comes into our plan and we are officially notified by ACA that they are enrolled, in fact, even just a little bit before that, because we kind of get a communication from the agencies that said there's a certain number of people that are headed down the pipeline, headed your way. That enables us to immediately mobilize a set of services and contacts and interactions with the family, so we can be ready day one to start our delivering services. We in fact are required by contract to have a face-to-face visit with each enrollee within 5 days of them becoming an effective enrollee. And in order to meet that standard, it's helpful for us to call the person, reach out to them even before the effective enrollment date. When we do that face-to-face visit, our care coordinators go through a comprehensive assessment process, working closely with the family, and we develop a plan of care that from that point forward guides the type and amount of services that the individual will receive, and works out any other arrangements that are a component of making sure that they get those services that they need. I think it's important to point out that one of the unique things that happens in this pilot is we intentionally made a commitment to the state that we would provide a very strong care coordinator system to this population. So we, again, are contractually required to maintain a ratio of no more than 1 to 18 enrollees. So each of our care coordinators has a caseload of approximately 18 people. This enables them to make sure that they are in continuous and constant contact and always available to the family if something happens, that there needs to be a change in the plan of care or some other kind of response to address a new need. I mentioned the 5 days already. We also are required by contract to meet certain provider adequacy standards. So we are constantly recruiting providers to join our network, to participate with us, and to serve this population. if you happen to be a provider, I'm not sure if we got a mixed audience, we have providers and families or whatever, but if you happen to be a provider and are at all interested and we haven't talked to you yet, let Callie or I know, or let Dina know, and she'll share the information with us, and we'll try to reach out to you as soon as possible. Because we've been trying to set up our system of care quickly, just to make it easier for the contracting process, we have often used APD rates as a benchmark, but we are typically paying above APD rates for units of service, and we are trying very hard. Although I will just admit to you up front, there have been a few bumps in the road, but we are trying very hard to offer a very smooth and easy to interact with system of filing claims and getting paid. In some cases, I mentioned the bumps along the road. That's happened because a lot of people that serve the IDD population are used to the APD mechanisms for billing for those services and getting claims. And although I've heard lots of providers in this world say that there are challenges with that system, nevertheless, you know, it's kind of the devil, you know, as a if you'll forgive the expression. And so our system, even though we think ultimately it's easier and more responsive and better to work with, it's different. And I'll tell you quite frankly, we have been recently beefing up our training capability and things like that to make sure that people can get used to our system as opposed to the APD system and interact with that. Going back to the fact that we are a provider service network, I'll just mention, we are very sensitive to the kinds of challenges that providers face in operating in this world and delivering the service, oftentimes with very slim margins and with lots of paperwork burdens and complications that make it every day a challenge to survive and be able to deliver services the next day. We get that. We are very sensitive to that, and we try very hard to smooth out those problems as we find them.
Hey, Carol,
I think I've been talking too long, and that's as much of an overview as anybody can stand, so I'm happy to respond to any questions.
I was just going to say, if people have questions, go ahead and put them in the chat or unmute yourself, because I know you did cover a lot of information.
Yes.
This is, like I said, going to be more of an informal Q&A, so be shy if you have a question. Okay, so we do have one question in the chat. What kind of documentation from providers for service provision, I'm assuming, are needed? Are they different than documentation required for APD?
Yeah.
So I'm gonna, Callie, do you want to talk about that?
Sure. Yeah, that's not a problem. We get that question quite a bit, and I can definitely understand why. So just so everybody understands, we, you know, at this point, although we definitely intend that we will expand, you know, we're a little fish in a big pond at this point. We are serving at this point where we, as of this morning, we have 325 members, and APD serves around 36,000. So we are not going to ask that you guys change your documentation at all. The difference will be that the documentation that you guys currently do will not be put on iConnect. You will not have access in iConnect to the individuals that are our members. But you will keep that same document, whether you're using something like TheraP, whether you are using something like Google Documents, things like that. We definitely want to make sure you're continuing that, especially if you have a licensed ADT or group home. You have to complete those documents in order to maintain that licensure. So there are no documents that are required for reimbursement in this platform. So again, more to come, you know, down the line as far as that concerned, but we don't expect you to change anything at this point.
Okay, so we have another question. This may be a loaded question.
Okay.
What rumors are you hearing that are not true?
Oh my. What rumors are we hearing that are not true? Carol, do you want to? I'm trying to rack my
Yeah,
brain. Go ahead.
It, but if the person asking that question is willing to elaborate a little bit more, I mean, I'll tell you, I live in Tallahassee and my work puts me in the middle of the political process. So that, I mean, we could spend the rest of the week talking
Okay,
about
this is Edward.
that, but I assume that's
I'll
not what
step
you're
up.
really interested in.
I'll step
Okay.
up. Edward
Okay.
Kem here, on the Treasure Coast in Martin County.
Okay.
And I just hear a lot of different, and I don't have specifics for you, but I hear a lot of concerns about the program. And I'm
Mhm.
just trying to look for more facts, to be honest with
Okay.
you.
Yeah.
And this is a great session. Thank you for holding it so you can try to help
Yeah.
us understand it better, but it's still, in my view, very vague about what
Okay.
we're getting. So if what I have a problem with is, how do you line this up, this
Mhm.
program up when it becomes available in my area to what we have today? And because there's no comparisons that are going on for us
Okay.
as parents that help us understand what the difference is, right? So
Okay.
that's
So,
kind of where I'm coming at it. And it was a loaded question, but it was an opportunity for you to kind of say, we've heard this, and we get this question a lot, but that's really not the way it works, right?
mhm.
This is the intent. This is what's actually happening. That's what I was kind of looking for, if that helps.
So Carol, can I start?
Yeah, sure.
Okay. So again, my name's Callie, and I definitely can understand, especially as a parent, the concern. So I'm just going to explain a little bit of my experience because again, I have a daughter who receives services currently on under APD, the I budget. So the big difference here is if you think of us as kind of like a one-stop shop, and what I mean by that is currently, if you are with the I budget with APD, your services that are provided with your support coordinator are essentially those IDD services. And that is what the support coordinator is responsible for ensuring those services are in place, et cetera. And there's a big provider, service table, rate table, et cetera. And all of the services that the I budget provides are in that spreadsheet, so to speak. And then in addition, if you have services under the I budget, you also have either like a Sunshine or a Simply as far as your Medicaid provider. So they're the ones responsible for your MMA, which is your medical coverage. Our platform is different and then it's all in one, it's all encompassing. So we have been a state Medicaid provider, like Carol was mentioning, since 2018. We are not new to being a Medicaid provider. We are new to this population. And so so the support coordinator for us internally is called a care coordinator. They essentially have the same role, but they are responsible not only for all of those same services that APD or the iBudget provide. So everything from residential habilitation, Life Skills 1 or 3 ADT, Life Skills 1 companion, personal supports, respite if they're under 21, between 18 and 21. They're also responsible for your primary care provider and your neurologist that you might see. And in addition, we're also covering those long-term care benefits. So if somebody needs in-home PT or physical therapy for post hospitalization or whatever that may be, that care coordinator is responsible for the entirety of that care, not just the IDD package. Because truly, if you think about it, and those of us who are parents as well as providers, we know that the medical impact can sometimes have a huge impact on their behavior and the services they might need to have in place, whether it's a temporary or a long-term need. So I hope that answers a little bit of
So
how we
can I
compare.
try to sum that up? So
Sure.
what I heard is that by using this program, you'll have one point of contact for
Yes.
all services,
Yes.
right? Opposed
Yes.
to more of a cafeteria style that you get through APD.
Um, yes, I would say that's a fair way of referencing it at this point. And I understand what you're saying. We were in a meeting last week and it's very hard to compare the services because we're not comparing apples to apples. We're comparing apples to oranges. Now, again, we are
Okay,
very,
so
go
look,
ahead.
let me ask you this. I want to interrupt, but
No, you're good.
that's where I think part of the rub
Mhm.
is from a parent's perspective, and you're a parent
Sure.
as well, so you
Yes.
understand this, but you're in the weeds of this all day long, so you definitely understand it much better than someone like myself.
Okay.
So, I guess how besides the coordinator, how does this make it simpler for us? For example, if I have a PPO for my own insurance, right, I don't need to go to a generalist to get a referral for a specialist. Does this give me a list of menu items that I can take advantage of for my daughter without going through a specialist? Like, how does this make it easier for me, comparing it kind of towards traditional insurance for people that are not on Medicaid? Maybe you can answer that.
So for anybody, any of our members who, so let's say, for example, and I'm not sure, but let's say your daughter receives insurance through you, and that's her primary. So nothing would change as far as that's concerned. That would still be her primary insurance. Her Medicaid would then become her secondary.
Right.
Yes, so
But in this
nothing.
example, assume I'm just trying to make an
Sure.
understanding so I can understand, or maybe you should take the current system, Medicaid versus this. How does it
Right.
make it easier for me as a parent to get services that perhaps I'm choosing them opposed to having to go through a service coordinator? Does it allow me, just like
Mhm.
I would in a traditional insurance perspective, say I want to go see this specialist? If of course they have to be in your network, but
Correct.
you know what I mean? Like, does it allow me to get access to healthcare easier, faster, or are we just replacing one system with another?
So I would say yes. And the reason I say that is because the reason I would say that is because you can reach out to that care coordinator rather than calling an 800 number and having to wait. We also have a very robust website. Like you're saying, you can choose, just like most websites, insurance websites, you can go see, narrow it down to an area, narrow it down to a specialist, and figure out where you're wanting to go. So I do think that it's a little easier, again, as far as having one contact. We give out, all of our care coordinators have to make sure that their members have their contact information, whether it's phone, email, and that they're accessible at all times. So again, I think that might be a little bit easier, but I can also funnel to Carol to see if she might be able to answer as far as the Medicaid piece a little bit better.
She's muted.
Okay.
Carol, you're muted.
I don't think so. Can you hear me now?
Yes.
Okay, I apologize. I want to answer your question as yes, but. Yes, it makes it better, but it's not perfect. And it makes it better because of that intense high level of care coordination that you're going to get. It's going to be a lot easier. And that care coordinator isn't a lone person, nurse or whatever, is the only one of it that has to be available 24/7. We also have a call center, we have a website, we have a complaint hub. We have lots of different ways to come to FCC and say, something's different, I need something else, I need to get something more, I need to get something fixed. So a lot of that is very, very responsive to the parents. But I heard you talking about those cases where you get to have some level of control over the resources that are spent for you. And one of the oversights in the setting up of this pilot has been that they did not include a consumer-directed option or a participant-directed option, as it's called in the long-term care program. We've talked to a lot of families that that's really important for. We get it. And we are giving feedback to the legislature saying that should be added to the program. That should be an option so that you can actually make your own choices about getting certain kinds of services and supports for your family members. So I would like to say, yes, it would make it better, but it's not quite perfect yet.
I have a question. Can you hear me?
Yes,
Okay, I'm Sue. I'm a guardian in Pinellas County and had some concerns with the managed care program that came in just recently. I have a lot of clients that have both Medicare and Medicaid. And so I question, it appears, and I might be wrong, that in these programs, it seemed like Medicaid was going to be the primary when I always believed that my clients, their primary is really Medicare, and we do have choice. And my concern about going into any of the managed care programs was they lose that choice. I have heard recently of people that have been assigned to those programs, not yours. You know, the doctor's 150 miles away. So there was a lot of issues in Pinellas County with these new programs for the Medicare, the Medicaid managed care program.
yeah,
Mhm.
really good issue to bring up, and we need to address it. And I want to start by pointing out that there have been a couple of things that have been going on that are changes that are happening that are affecting Medicaid in Florida that aren't specifically part of the pilot. But people who are trying to learn about the pilot are frustrated by these other things. And one of those was what you might have been referring to is the Agency for Healthcare Administration
Yes.
changed its policy for voluntary enrollees in managed care, and they moved it from before you had to, if you were voluntary, you had to actively opt in to a managed care plan. And what they did with the new contract that started as of February 1 is they turned the people with developmental disabilities into an opt-out category. So they are assigning people into a plan, and you have to get through to their call center and their choice counseling center in order to get out of that plan. That's not the pilot, but it is managed care, and it has been very frustrating and confusing to a lot of people. So I wanted to mention that. And the other thing I wanted to say, as far as we are very familiar with people that also have Medicare coverage. In fact, in our long-term care plan, about 95% of our enrollees were duals, and their primary insurance for those services that are covered by Medicare was their Medicare plan.
Okay.
But Medicaid comes in as a secondary payer for uncovered services or to pick up the cost of copays or other kinds of cost sharing obligations that an individual might have. And that same arrangement will also apply to people who have dual coverage who come into the pilot.
Okay, does that answer your question, Sue?
Yes, it does. And Callie, nice to see you. I know Callie from years ago.
Yes.
I'm assuming that your care coordinators also replace your, what we would call a support coordinator.
Yes.
Okay,
Yes.
and I came in a few minutes late. I apologize.
No, that's okay.
So I just wanted to confirm that this is a different system, and that it replaces that person.
So
Would you-
yes, actually, go ahead.
Okay, do you still have support plans and those types of things like you do for the iBudget for
Yep.
people? Okay.
Great question. Yes. So we are required to do all of the same required paperwork that APD does with their support coordination. So our person-centered support plan is completed within 5 days of them becoming active with us. And their services have to be in place, I believe, within the first 7 days. So yes, that care coordinator is responsible for the exact same thing. They are full-time employees with Florida Community Care at this point. So yes, they have exactly the same responsibilities.
Okay, thank you.
Yep.
I do have a couple other questions in the chat that I wanted to bring up. One,
Dana,
I'm sorry, Carol?
can you hear me? I wanted to follow up on that
Sure.
just a minute, if I could. Because what Callie said is absolutely, of course, correct. But because of the nature of this pilot program, when we establish that care plan, it's not being used as a tool to manage money that's available in the system, the way the iBudget system does. That's a cost plan in the iBudget world. And any change to that affects the expenditure in the program. So it's managed differently. In our world, it's a care plan, and it is laying out our obligations to deliver services to our enrollees. And that's why our care coordinators are empowered to make changes in the care plan. If they're interacting with the individual and the family in a way that's identifying a new need that wasn't contemplated before, or some other change in situation that needs a change in that care plan, our care coordinators are empowered to make that change, and that change, that care plan then acts as the authorization to pay for services, whatever is in that care plan. So that's a way, going back to Edward's question, that it makes it easier for the family. You don't have to wait 60 to 90 days for the central office in a large organization to finally approve a change in your care plan.
Great,
Yeah.
thanks. Okay, so next question. What is the process for provider complaints from individuals and how those are handled? For example, no show for scheduled services.
So we have a complaint line, a call center, and a provider relations team that all respond to issues that happen. And in order to resolve that complaint, and we have contractual obligations to resolve complaints within a certain period of time. And I'm sorry, I don't remember exactly what that line is, what that deadline is, but we do have multiple ways to solve those kinds of problems. I think I was on a call this morning that suggested that most of our provider issues that come into our call center are resolved within 2 days. So we're at like 90% are resolved within 2 days. So we try to be very responsive. And we've also set up certain benefits that enable us to pay providers differently than you might be used to being paid by APD or some other fee-for-service system. So for instance, I don't know what kind of provider you might be, but if you are a small group home and one of your residents goes into the hospital for a few days, we'll continue to pay you for those days. They're called bed hold days. And we don't want you to lose that revenue stream in a way that would potentially threaten your ability to continue to serve our enrollees. So we pay you while they're in the hospital. And there's other kinds of situations where we will make sure that the provider gets paid. One other quick thing to mention to you is the continuity of care provision. And this is important to anybody who's been in getting Medicaid benefits in another way, or frankly, even, some other kind of insurance coverage. We have a contractual obligation with an enrollee that comes into our plan to cover 180 days the same service that was authorized under whatever previous system they got at least the same rate, if not higher. And we've been implementing that policy for 180 days of continuity of care in a way that actually sometimes is pushed out to even more than 180 days if the individual circumstances require that. We're trying during that period to set up a contractual relationship with that provider, but we will absolutely meet the obligation to pay for that service, even if we haven't finished the contract negotiations.
So that's talking about a nursing home placement or something like that after hospitalization?
It could be, or frankly, it's a lot of physician services as well. So, or it could be that you had an appointment for a therapy or a diagnostic test of some sort. If that was set up under whatever previous system you were in, we will continue to honor that obligation and we'll pay for that within that 180-day period.
Great, okay. Are there co-pays to the family or the individual?
Medicaid coverage does not allow any copays.
Okay. Regarding residential providers, is FCC expecting residential providers to meet all of the service requirements of the iBudget handbook?
So currently, due to the fact that APD is the licensing entity for residential group homes, they do have to still follow those mandated licensing requirements because we are not the licensor. So for now, as the pilot program, yes, they would have to maintain everything they're currently doing for that APD licensure.
Great. Okay, so regarding behavioral providers,
Mhm.
do the requirements they need also apply to your individuals? Are the providers required to attend and get plans approved by the LRC? Do they have to report any reactive strategies?
That is a great question because we are currently in the process of speaking with ACA about that, those requirements. So there is no LRC with the FCC pilot. There is, however, we do have an internal BCBA as we grow, potentially more staff, and we will be conducting essentially something like the LRC, but it will be in-house for now. We're looking at ways to obviously ensure appropriateness of behavior plans and things like that. But so we are in the process of working on that policy and procedure, so to speak. But for now, yes, the behavior assessment will be ordered by the care coordinator. So the FBA will be completed, and then we will look at for a behavior plan to be completed. All of those entities will be submitted through our platform.
Great. Okay, so here's another provider question regarding if a client has their Medicaid dropped at random and then as a provider, they don't get paid for that month over a year, would that same issue happen in this pilot program? And you're muted, Carol.
Not though, I'm trying to yell at the screen. There we go. Can you hear me?
No,
Not really.
Testing, testing.
I think it's.
There we go.
There
I
you go.
see. Okay. I think this question is coming out of the problems that relate to the redetermination process. I suspect rather than anything directly having to do with the pilot. And I absolutely agree with you, as I know Dina does and many of the other folks we've been working with, that process has been a nightmare. And although hopefully DCF is doing some things now to smooth it out. As for FCC, if we somehow or other have one of our enrollees who gets caught in that breakdown of that redetermination process, what we've been doing is bending over backwards to make sure they continue to get services and providers continue to get paid while we work out the details of the Medicaid eligibility.
Will the pilot program provide live-in personal support?
So currently, all of the IDD benefits that are under the iBudget platform are the same services that we are providing.
Great. So are the providers that are coming from long-term care plans receiving training on how to support this population?
So that's a very good question as well. So we have very limited long-term care providers that are providing supports for this population. And the only way that they are receiving LTC or long-term care continued services is if they were receiving them through their long-term care Medicaid provider prior to coming into the pilot program. So we are not referring new members to a long-term care provider. We would prefer that they are with an IDD provider, as again, there's different training, different expectations, and obviously those are the individuals we want them working with.
Great. What about the continuity of staff in the program? Do you try to keep the same staff with the individual, or is it just on an availability basis?
So if someone has been working with an individual, again, prior to coming into the pilot, we want to emphasize that continued relationship and that continued support. So again, we are working very hard for that, with that continuity of care period, to get that provider within our network. We've definitely done that multiple times so far because, for example, maybe individuals that were not necessarily receiving long-term care, but they were paying out of pocket. We've seen that a lot with ADT, especially. So a lot of those members maybe were going to day program twice a week, and we immediately pick up that and they're going 5 days a week. So we definitely want to continue. We know those relationships are incredibly important to continue.
What is the care coordinator's responsibility in terms of the medical side of the client's care?
That's a good question. They're responsible for essentially knowing when appointments are. They're responsible for ensuring that medical appointments are being met. Both that we have, the majority of our members are, of course, are living at home or in family homes. We have a couple who are living residentially, whether they are currently in an ALF, or we have had one member we've placed in a group home, and I believe we have one more in the process of doing that. Oh my goodness. Yeah, I'm sorry. What was the question? I completely blanked.
Let me get back up there. Oh my goodness.
Yeah.
The care coordinator's
Oh,
responsibility
yes.
in terms of the medical side.
So because we are, like I said, we're a comprehensive plan, so the care coordinator is responsible for the medical care and ensuring that if the primary care wants a specialist involved, that specialist is seen. We do have, it is a little bit different here as far as we have separate departments that are constantly working on this population. We have obviously our care coordination team, their sole responsibility is the member. We have a provider relations team. If that care coordinator needs a new neurologist, cardiologist, whatever, then they ask provider relations to get involved and be the ones that are stepping in on that priority. We have a separate billing department. Those are the trainers to make sure that the providers are getting trained in that. And then we have a separate claims department. So it's not just the support coordinator. We have quite a few team members trying to make sure that all expectations are met.
Do you have enough adult day training to serve the individuals already in the pilot plus ones that will be coming on?
That's a good question. I would say we are always looking for ADTs. I would say the top 3 services that we are being asked for are companion, personal supports, and adult day training. So we are always looking for additional adult ADTs for sure.
Will medical practitioners still be able to come to the home?
Yes, absolutely.
Okay, let's see. I'm going through. Is it correct that to enroll in the pilot program, you have to enroll in the FCC managed care plan?
So yes, right now, if you're wanting to be in the pilot program, it's everything comes over to us.
And I wanted to respond to that
Yep.
as well. Because again, I see in the chat that question is partly involving whether or not what happens or what is the effect of enrolling on the pilot on those other sources of covered services that you have, like Medicare or Blue Cross Blue Shield. And you could still have Medicare coverage and Blue Cross Blue Shield coverage and be in the pilot. What the pilot will do for you is be your source, and FCC would be your source in that case for Medicaid covered services and all of the enhanced benefits that are built into the pilot program, but it would not disrupt your Medicare coverage or your private insurance.
Did that answer the question there, Phoebe? No, I think she's still on. And then we have questions on what are the requirements to become a provider.
So I will put my email address in the chat for anybody who wants to reach out to please reach out to me.
Right, and we'll include that
Yeah.
when we send out a copy of the flyer. and other information. We'll include that as well. All right, so with the proposed cuts to Medicaid, why would we do this? And I'm assuming that the question is, why would we get onto the pilot program?
Mhm. Can't hear you again.
I know, and
There you go.
I
There you go.
I have not once pressed the mute button. It's my microphone is only working occasionally. Okay. So right now, I know there's talk about the possibility that the feds will cut Medicaid, but in some way, but I think that's a long way from happening for a variety of political reasons we could discuss if you want to. More importantly, and closer to home, the Florida legislature is getting ready to come into session and work on its budget. And there is no conversation that's been happening so far of any explicit cuts in the Florida Medicaid budget. And then the other thing with the pilot is you're getting more for less. Well, the way FCC gets paid is per member per month. That's like a premium payment that gets paid to us. Then we're obligated and we bear the risk for all of the services that we are required to provide, whether or not we can do that under the amount of money that is available to us. So that's the risk that we bear, is that somehow or other costs would exceed that, but the state wouldn't be on the hook for that. And remember, Callie mentioned earlier, we cover 3 kinds of benefits. We cover all of their medical needs. We cover any ordinary long-term care service like home health or DME or those kinds of things. And we cover the specialized IDD services that until the pilot was created were only available through the iBudget waiver. All of those things are covered under our premium, and it frankly is a better financial deal for the state than other mechanisms of payment. And that's why I was talking earlier about the success in the long-term care world. That financial calculation and the savings that can be produced through a managed care model, and the efficiencies that can be accomplished will enable the state to serve more people with either the same amount of money or something comparable.
Great. So I know that I think I covered all the questions and we are at time. We appreciate everyone putting in very good questions, and Carol and Callie taking the time to kind of walk us through it. And like I said, we will send out the informational flyer along with Callie's email. So if you have specific questions, you can reach out.
Absolutely. Anyone can reach out, parents, providers, anyone, support coordinators, feel free.
Great.
Great.
Thank you, guys.
Thank you.
Thank you.